Good morning, everyone. So we do vitrectomies. Approximately 30% of the patients who undergo PRP need vitrectomy. So that's not the issue. So as the complexity of the PDR increases, one of the paper has retrospectively reviewed how many patients needed vitrectomy. So you can see a PDR with a vitreous hemorrhage, with a TRD or more complexity, nearly half of the patients might need vitrectomy. But as you see, vitrectomies, we have got vitrectomy we do for three indications, either vitreous hemorrhage, for TRD, or for tractional DME. The most important point is that TRD has got very poor visual outcomes. Hardly 50% of them will have some improvement in vision, and even 19% of the patient can lose vision after surgery. So there is a need to identify which eyes are prone for tractional complications at baseline, at the time when you do the PRP. That's important because it will reduce the incidence of the prognosis will be better. So after reviewing all our cases, what we found that as far as the tractional complications, which are very important to prevent, which will cause a significant vision loss. If you have a vitreous hemorrhage, there is no problem. Even if you operate after 6 months, there is no problem. The vision outcome will be good. So there is a specific kind of features in the fundus which will predict you which patients will develop a macula involving TRD or a peripapillary TRD. So it's the location of new vessels. So you have vessels which are on the disc and around the arcades, and the area of new vessels. So if you have a very small patch of new vessel NVD, that is not very significant. So if the area of new vessels is very large, then the greater risk. So these are the two most important risk factors for predicting the onset of tractional complications in diabetic retinopathy. So when you see such a patient, you have to have a plan of immediate PRP followed by early vitrectomy. So many of these patients have got excellent vision, so they might not agree to undergo vitrectomy. So those who refuse surgery, we have to have a very close follow-up, because it's a matter of time before they will have developed tractional complications. And the timing of vitrectomy is very important. The earlier you do, you will have a better visual outcome. So you can see this is a patient of a bilateral PDR. Right eye you can see has already got a tractional complication, and in the left eye you can see there is a PDR, HRC PDR. So if you look closely in the left eye, you can see that there are a lot of leash of new vessels which are very fine. You have to look in the high magnification, and around the disc and around the arcades you can see lot of new vessels. So you can see 6 months later we have operated the right eye. It is having siliconal inside the eye. It needed a localized retinectomy also. It was a complicated case. So 636 vision, and within 6 months of doing PRP, you can see this patient has developed the same problem in the left eye also. So when we operated, again the visual outcome was suboptimal. The best outcome was 636 possible in this patient. So that underlies the need that we need to do early vitrectomy in such patients. So this is another patient. He has undergone PRP. This is 3 months post laser, apparently doing okay, and this is after 14 months. 1 year later, patient has developed a central tractional complication, and his vision is reduced to just hand movements 1 meter. So when we operated this patient, our visual outcome was only 3 meters. And the other eye has got vitreous hemorrhage with a small traction, so he had a better visual outcome. So this underlies the need that you need to operate them earlier and follow up very closely. This is another case 3. You can see at baseline large leash of vessels in the central disc as well as along the arcade, bilaterally same presentation. So he underwent PRP, looked fine at the end of 3 months, looking okay. So 5 months later, you can see after PRP the tractional problems have started occurring. So in bilateral you are seeing the pre-retinal hemorrhages developing. So he agreed to undergo surgery in one eye, and you can see immediate surgery which we did, the visual outcome was good. Vision was 618, same as the baseline. For some reason he was not able to undergo surgery in the right eye, and you can see the vision has gone to PLPR within 9 months, and still he has not undergone surgery in that eye. This is a case 4. You can see again similar scenario, bilateral central vessels, and the left eye, because it was having poor vision, he agreed to undergo surgery. So after early surgery, the vision recovery was 6/12. In the right eye, because he had good vision in the other eye, he developed bleeding in the right eye, but still because he was seeing, he did not present early. So 6 months later, with a partial PRP, you can see this patient has developed a tractional detachment, and his vision has gone down, and he has undergone surgery, but his vision is only 3 meters. So if you would have done early vitrectomy, this patient would have got better vision. This is a case 5. Again you can see a similar patient, bilateral central vessels beginning to contract, and one eye 624, other eye 6 hand movements. Sometimes the patient progress very fast and you don't have time. Within couple of weeks they can become blind. So you can see in both eyes he has undergone vitrectomy, though it was slightly late, but this kind of result you will not get in every case. It will be a rarity. So majority of the patients who have a large area of neovascularization on the disc and along the arcade, that is the central new vessels, you need to plan PRP followed by early vitrectomy. Otherwise they will have adverse visual outcomes. This is the message I wanted to convey. Thank you.
Yeah.
No, you do PRP and do early vitrectomy. So within 2-3 months of PRP. No, in our series we have seen every patient develop TRD of the macula. Every patient. It's just a matter of time. Some patient develop at 3 months, some patient develop at 14 months, 16 months, but every patient develop TRD and lost vision. It causes traction because once the vascular part goes, then the fibrosis starts.
Dr. Sharad, I think another modality we can use, like little bit on the conservative side, giving intravitreal injection anti-VEGF along with PRP when the neovascularization front is flat.
That we have given in many of these patients. Okay. We have given even anti-VEGF for this patient, but it doesn't. What we have seen, even the natural course, even if you don't do PRP, anti-VEGF, these patients will end up into same problem. If you do PRP, they will end up into same problem. If you do anti-VEGF also, they will end up into same problem. That is the natural history of the disease, because the vessels are so large, complex. Once the VEGF goes, the CTGF takes over, and then the tractional problem takes over. So all of these patients need vitrectomy. See, we have got around 40 patients.
Very well documented, Dr. Sharad. The only one thing I would also have, my experience also been similar. Could it be possibility that the pattern laser is not working as good as the single spot laser that was?
Yeah,
pattern laser is not so effective.
There is a literature review which says that that the vitreous hemorrhage incidence is more in pattern laser and the regression of retinopathy is less or less. But I feel that we are not used the pattern laser in our patients. All patients are single spot laser.
Okay, that's.
Though we have pattern laser, we don't use it. We are not convinced. So we are using single spot laser on the pattern laser.
Okay, I think it doesn't matter whether single spot or pattern. My experience have been similar to you. Pattern laser, I was of the opinion that pattern laser is not working good and single spot is better. So
for HRC PDR, you need to use the single spot laser. Less severe forms of retinopathy, pattern laser is okay. I mean, it's not that it doesn't work. Yeah.
Thank you.
Thanks.
I have just one point. Dr. Sharad has nicely managed all the cases, but as far as the photograph shows, I have one suggestion. As if we do some what you call more savage laser, like coming just 500 micron up to disc and on the lasering on the flat NVs and macula also, there is temporarily lots of area vacant. If we come slightly closer up to 2 disc diameter, I think maybe few patients may have avoided vitrectomies maybe.
We don't know. I mean, as best possible, PRP has been done for all the patients. And we can't come too close to the membrane because again, that's the problem. You have to leave at least 1 disc diameter.
No membrane. Of course, the membrane is there. I mean, you have to mentally prepare the patient.
The problem is that the vessels will regress. The only thing is that the next thing is tractional complication will occur, whatever you do. Yeah, thanks.
Thank you, Dr. Sharad.